Now I'd like to introduce Chisato Hamashima from Teikyo University. Dr. Hamashima is a professor of health policy in the Division of Nursing and Medical Technology at Teikyo University in Tokyo, Japan. She's been intricately involved in the development of cancer screening guidelines on a national level in Japan for the last 15 years.
Thank you for kind introduction. I'm happy to be here to present Japanese gastric cancer screening system. Today, I'm focused how endoscopic screening is being introduced as a national program in Japan. Although the incidence of gastric cancer has decreased worldwide, it is the fifth most common cancer in the world. In 2018, more than 1 million cancers and 800,000 deaths occurs globally, according for 6% of total new cancer cases and 8% of total cancer deaths. Although the incidence of gastric cancer has decreased worldwide, incidence differ from country to country. This gastric cancer has been common in Eastern Asia countries, particularly China, Korea, and Japan. The burden of gastric cancer has thus remained in these countries. In Japan, a national program for gastric cancer screening was introduced into the law in 1983. We have 5 cancer screening programs. We have two screening methods for gastric cancer screeneening. The target age of gastric cancer screening is from 50 years without upper age limit. First, we have a long history of gastric cancer screening, for which the radiographic technique was originally developed in Japan. Radiographic screening using upper gastrointestinal series has been recommended since the introduction of gastric cancer screening. Recently, in 2016, Japanese government changed their policy and approved biannual endoscopic screening for gastric cancer for individuals for age 50 years over. Cancer screening guidelines have contributed to the promotion of evidence-based cancer screening for the national program in Japan. Then this is a flowchart of how to introduce a new technique as a national program. National Committee, first, National Cancer Center developed cancer screening guideline and then submit this guideline to government. The government have a national committee, and this committee has discussed appropriateness of introduction a new technique as a national program based on the National Cancer Screening, National NCC guideline. To reduce cancer mortality, cancer screening needs to be performed in the effective manner. We have developed cancer screening guideline since 2003 at the National Cancer Center of Japan. In the first version, we cannot recommend endoscopic screening as a gastric cancer screening strategy. Then, in 2015, we revised gastric cancer screening guideline, and then we recommend endoscopic screening. This is a flowchart of how to introduce, of how to recommend of endoscopic screening for, as a national program. In the first guideline, we cannot find any evidence to reduce mortality from gastric cancer by endoscopic screening. And then case control study was conducted in Korea and Japan, and then we developed new guideline based on these studies. At that time, we found 3 case control studies, and then we recommended endoscopic screening as a new strategy of national gastric cancer screening. Based on our guideline, Japanese government approved endoscopic screening. This is a recommendation grade of new guideline. New guideline recommended radiographics and endoscopic screening, but other strategy, pepsinogen, pepsinogen, and Helicobacter pylori antibody were not recommended because of insufficient evidence. Usually, the new technique, introduction of new technique as a gastric cancer screening was when we introduce new technique for cancer screening, developing process was defined by this process developed by Pepe. Phase 1 and Phase 2 are conducted in clinical practice, and Phase 3 to 5 to evaluation the effectiveness or efficacy for cancer screening. When we developed the first guideline, we cannot find Phase 4 or Phase 5 study of endoscopic screening. However, we found primitive studies on the Phase 3 study at that time. To make a recommendation, we accumulated study from Phase 4 to Phase 5. The calculation of sensitivity and specificity of endoscopic screening was the first step to evaluating the effectiveness of endoscopic screening. You can see the sensitivities of comparison of sensitivities of endoscopy and radiography for gastric cancer on the slide. In the prevalence and incidence screening, sensitivity of endoscopic screening is always higher than radiographic screening. However, specificity is similar among endoscopic screening and radiographic screening. And next, we move to the Phase 5 study. We evaluate mortality reduction of gastric cancer, usually based on mainly case control study. When we developed the guideline, we found 3 case control studies related to endoscopic screening. One is one from Korea, 2 from Japan. Today, I introduce the main result of the bigger case control study conducted in Japan, because one study is very small sample size. We conducted a community-based case control study to evaluate reduction in mortality from gastric cancer due to endoscopic screening. Our result suggested a 30% reduction in gastric cancer mortality by endoscopic screening compared with no screening before the date of gastric cancer diagnosis. This is Korean nested case control study. This study was performed based on the national database. Therefore, they used more than 50,000 pairs. In Korean's nested case control study, the mortality reduction from gastric cancer was 47% among the participants who were ever screened by endoscopy compared with never screened. And there is no significant mortality reduction in radiographic screening. Now we can find 4 case control studies compared with endoscopic screening and no screening. This is the result of meta-analysis of 4 case control studies. Although the result obtained, although the result obtained from case control studies were limited, all study has a positive result from mortality reduction from gastric cancer. 23% mortality reduction from gastric cancer was expected based on the meta-analysis. After the approval of Japanese government, we made a quality assurance manual. To implementation endoscopic screening for gastric cancer, we need a quality assurance manual to implement endoscopic screening correctly. The quality assurance manual defined basic requirement for endoscopic screening for gastric cancer. This is outline of quality assurance manual. The management system implementation procedure and strategy for harm management are mentioned. This is target population and national program of gastric cancer, national program of target population and screening interval of national program. In Japan, municipal government have responsibility for cancer screening implementation referred to national policy. The Quality Assurance Manual therefore recommends creation of specific committee for the management of endoscopic screening. The committee accredits the preferred examiner for endoscopic screening and then manages interpretation meeting for the double-check system. The committee also collects the result of cancer screening result and adverse effect. The quality assurance, our manual defined qualification of examiner. First is specialist. Second is physician who have performed over 100 endoscopic examination per year. However, some area, particularly in rural area, there is an insufficient physician. When considering such a context, sometimes examiner accreditation who is not expert, who has insufficient evidence, sufficient experience, might be approved at that time. We also we did not define endoscopic type in this manual. Recently, examination of nasal endoscopy have gradually increased because of the request based on the request of the examinees. Preparation of automatic processor is required for infection control. This is the result of time study of endoscopic examination. Actually, examination time is limited to 10 minutes. However, preparation and after post-procedure is needed longer time than actual examination. Most of the preparation, pre and post procedure is usually conducted by nurses. Therefore, endoscopic screening is important role of endoscopic screening. We have original system of double check system. It is our original system for implementation of endoscopic screening. First, the examiner makes a primary diagnosis and submits the result to the local committee. Expert then perform a second check and give the final assessment. All results should be checked by expert to ensure the quality endoscopic screening ensure the quality of endoscopic screening remains high. Final assessment is based on the biopsy also based on referred to biopsy result and divided into 4 categories: no finding, suspicious of gastric cancer, and gastric cancer, and malignant disease, not gastric cancer. If expert find another location which is suspicious of gastric cancer, they recommend additional examination. This is one example of the result of double check system. Additional cancer could be diagnosed using a second check, and this system is also effective for training of endoscopic screening for a physician who have less experience. Actually, there is a harm of endoscopic screening, adverse effect including perforation and bleeding, and false positive and overdiagnosis. And this is a result of result of the adverse effect reported by 2 academic societies in Japan. They reported an adverse effect rate 5.02 per 100,000 cases, and death rate is 0.19 per 100,000 cases. This result is different among 2 academic society. The reason of the difference is their target subject were actually different. And another problem is overdiagnosis. Overdiagnosis is a serious problem of cancer screening. IARC defined overdiagnosis. It is detection of cancer on screening that would not have been found were it not for screening test. However, there is no actual data in endoscopic screening, but we have to consider overdiagnosis problem in endoscopic screening for gastric cancer. This is example of our screening experience result. The observed number of gastric cancer diagnosed by endoscopy was twice that of expected number. This result does not show the advanced technique applied at National Cancer Center. The excess number include early diagnosis in the preclinical phase, its actual screening effect, and also include overdiagnosis case. Although endoscopy can detect many early cancer, there is a possibility of including overdiagnosis. The American College of Physicians has recommended high value care based on the value framework. The value of cancer screening is determined by a trade-off between benefit and harms and cost. As intensity of cancer screening increases, the benefit of cancer screening rapidly increase, but it stopped optimal level. However, harm and cost has growing constantly. Therefore, the actual screening value is stopped at optimal level. Intensity of screening and frequent screening is not beneficial because of based on this theory. Therefore, in our manual, we recommend management of strategy of harm. For false positive case and overdiagnosis, we recommend avoidance of frequent screenings. And we also try to define of starting and stopping age. For infection control, appropriate screening and in disinfection, and installation of automatic processor is needed. For adverse effect, careful examination is needed. We have another program to introduce of endoscopic screening. In Japan, radiographic screening is still major screening method. At present, about 4 million radiographic screening are performed each year, whereas the total number of endoscopic examinations performed each year in clinical practice is about 12 million. If 30% of gastric cancer screening was replaced by endoscopic screening, the total number of endoscopic examination would increase by 9%. That is by about 800,000. If the participation rate increase from 5 to 20%, but the percentage increase endoscopic screening, endoscopic examination needed will be 30%. If the 30% gastric cancer screening were replaced by endoscopic screening, 85% an institution is large city could perform endoscopic screening with a 10% increase in the number of endoscopic examination. However, only 45 of the small municipality group are available for endoscopic screening with a 10% increase in the number of endoscopic examination in rural area. There is a huge disparity between urban and rural area providing of cancer endoscopic screening. Helicobacter pylori infection is a major cause of gastric cancer. HP antibody serum pepsinogen have therefore been expected as a predictor of gastric cancer. Actually, compared with cases negative for both, the risk of developing gastric cancer increased with any positive. In Japan, a combination of HP antibody and zerpepsinogen, so-called ABC method, has been commonly used. Ability of prediction of HP antibody and zerpepsinogen is not so high, even if the combination was changed. Although sensitivity to predict gastric cancer development is over 90%, the specificity is much lower, only 20%. The prediction model using H. pylori antibody and zelpesnogen is inappropriate because the false positive is high. This is an example of HPV testing of cervical cancer screening. The cumulative incidence of precursor region at second round for the pap smear, pap negative group is equal to that the third round of HPV negative group. This result suggests that HPV test could more adequately predict the development of cervical cancer than cytology. This concept can be adapted to endoscopic screening, considering to the risk of gastric cancer based on the HP infection and atrophy. The screening interval can be expanded. Nowadays, at present, screening interval of endoscopic screening 2 years. In Japan, the screening interval can be expanded by as much as twice the regular screening interval in low risk group, which can be divided by HP infection and atrophy. This is final slide. Although endoscopic screening could be introduced in Japan, several problems remain. To reduce harm, immediate definition of target age group is needed. And collaboration risk stratification method is one of the options to expand screening interval for low risk group. And also, we need improvement access. We always consider improvement of access to endoscopic screening. Thank you for kind attention.